Thank you again for your participation this morning. Just as a reminder, there are question cards on your table, so as you have questions, the moderators will circulate to collect those. Also, there's a blue sign-in sheet for this session. We will ask you to sign in at each session, regardless of whether you are an ACHE member or not. So for this session, it is a blue sign-in sheet. At this time, it's my pleasure to welcome to the podium our session moderator, Dr. Becky Taylor. Dr. Taylor serves as Assistant Director of Quality, Safety, and Decision Support at ProMedica. Becky?
Hello and thank you. Our next panel will focus upon leaders engaging high-performing teams. Here to walk us through strategies for accomplishing this are three Ohio healthcare leaders. First up, Dr. Bradley Martin serves as Chair of the Department of Medicine as well as Vice President for Medical Affairs at Summa Health System in Akron, Ohio. He completed his medical degree at Marshall University and holds a Master of Hospital Administration degree from Ohio University. Dr. Martin has been a leader in sepsis mortality reduction and antimicrobial stewardship, to cite just a few. Please join me in welcoming Dr. Martin.
Good morning. It's really interesting always to talk about high-performance teams. When I started at Summa as an intensivist 30 years ago, and the senior faculty turned to me and said, "Fix this problem," who knew I was really a high-performance team at that time? But things change. We have several things to talk about. One I'd like to talk about is, some of the processes we've had for high-performance teams. It includes sepsis. It includes telestroke. It includes some teams that related to antibiotic stewardship, as well as others. So we'll kind of go through these. I'm going to focus mostly on sepsis because that's where we started. The sepsis group, among other things that we did to enhance that service, was to, one, define a very small team to get things started. And that team met on a regular basis every 2 weeks when we started that initiative. Those initiatives included establishing the coding process with sepsis. It also included establishing some education, our Muse. And I apologize, I really can't see the slides here, so I'm going to kind of step around here so we can you can see them a little better. And also, at any rate, the sepsis group, as we went through things to set this up, some important, I think, strategic plans we had with that. One is to keep the group relatively small. And I think you start out with individuals that are very engaged in the process, particularly with sepsis, that they're engaged with that. And you take these people that are highly motivated and change them somewhere between zealots and Cape Crusaders to get the process done. So we started out first looking at order sets. We did a number of things with the order sets. We had a smaller subgroup that looked at setting up our sepsis order set, defining them, and when we went on to Epic May of last year, we were on our third version of those order sets. Some other things that we did to help with that was for the intensivists, it was part of their metrics for bonusing that they use the order set. So we use it as a process. We have a closed ICU. That was also helpful in using that process. Coding guidance. The initial group included some individuals from the coding department to help us train the medical staff about coding, as well as educate the staff. It amounted to posters, screensavers that we utilized. We also had a sepsis fair that was very helpful in this process. The sepsis fair included an oral quiz that if you got 3 questions right, you got a chance to dunk either the chief medical officer or one of the intensivists. So there were an impressive number of people committed to academics that day and doing these quizzes. So that was helpful. We started out with a medical early warning system, the Muse system. We were using an Allscript product at the time. It was a little too sensitive and not specific enough, so that didn't work well for us. We elected at that time to use our dedicated rapid response team to simply round and ask who was on the floor, who was sick, who had issues. We used badge backers also to help us. The nursing assistants had badge backers that they utilized, that if somebody somebody met criteria, it was a little modification of the Q SOFA. If they met that criteria, we utilized those nursing assistants to let the nurses know that they had a potential septic patient and to reevaluate that patient. We had a number of quality incentives that we did improve using this process, identifying patients who are potentially septic. And I will tell you that the most useful things that we probably did with that group was to do an action registry with timelines and with people responsible for that. So when we did meet on the 2-week basis, we could follow that timeline and follow the progress of those initiatives. We now have an EMS initiative that we're using the Q SOFA process with EMS to identify potentially septic patients and start the fluid resuscitation with those individuals. The coding and other parts of this are very difficult, particularly with sepsis. As you may or may not know, Medicaid uses one criteria. They use the Q SOFA criteria on a lactate that is greater than 2. Medicare uses the Sears criteria with a lactate 4 or greater. So it depends on which insurer you have as to whether they meet the criteria. What we do on a regular basis is that the Vice President of Medical Affairs and Vice President of Surgical Affairs meets with coding, and we go case by case. When they have coding has a query or they have a denial to determine whether the patient has met that criteria or not. And from there, we do the peer review process or ask the physician to change the coding in the chart to meet that criteria. So that's been kind of an ongoing issue for us. We tackled sepsis pretty early on because we knew that we had a higher than expected mortality with that. Part of it, I believe, was our overall coding process. Patients that did not meet sepsis criteria were being coded as sepsis, and I think we were missing some patients. A typical thing for us is a patient who comes into the emergency room with pneumonia, transiently gets hypotensive, gets fluid resuscitated, we didn't tag as sepsis. So if you died from pneumonia in the intensive care unit, you always died of sepsis no matter what. And that's how we were tagging patients. And we continue to run into those issues, so we continue to push that coding process with our patients. So maternity care we've looked at, and I will shamelessly say that if you want more information about maternity care and about the telestroke, there's some wonderful posters out there from SUMA if you want to get more information on those. But the sepsis process, maternity care, we looked into as well. So, I'm sorry, I can't. I'll have to admit these slides do not look familiar. So let me go back. I think these are somebody else's slides. Apparently so. So the other processes that we looked at, certainly our antimicrobial stewardship process was a high-performance team initially. Great success, nearly $1 million of savings from that group. Telestroke program introduced robots in the process to providing stroke care in our hospital at 2 locations, utilized not only by distant physicians, but our local neurologists. And we also use the robot for critical care as well at a second site. As I said, the OB process that we've utilized included patients with opioid addiction. We have a large Nepalese population and communication issues surrounding that we had a process for, as well as minority care for obstetrics. We also had an initiative that utilized behavioral health embedded in our primary care residency training programs, licensed social workers, and that has been very successful. A number of very difficult to manage patients we've utilized those individuals in as well. Anecdotal stories, we had a dialysis patient, frequent admission to the hospital. After meeting with the social worker, it was determined that how she was treated at the dialysis center was affecting her desire to go get dialysis. After resolution of that problem, her frequent admissions went away because she showed up and got dialysis. And that would have been unrecognized without input from a social worker to actually sit down and ask her what was going on with her dialysis treatments. So I think the use of high-quality teams is important. The importance with that, as stated earlier, is input from administration to support those teams financially and structurally and logistically to get their goals accomplished. High-performance teams do not necessarily mean higher cost. Often savings from those groups can be attained by utilizing better processes, simpler processes from those high-resolution teams. In addition, I believe that it's lead for innovation for every institution are these high-resolution, high-performance teams and their outcomes. So I think that, as far as quality improvement, having these teams drive that quality is the key for our institution. Okay, thanks.
Thank you, Dr. Martin. Next up is Sara Brokaw. Sara serves as Vice President of Patient Care Services at Bellevue Hospital in Bellevue, Ohio. Sara holds a Master of Science degree in Nursing Leadership from Walden University. As an executive sponsor of many clinical improvement initiatives, she has successfully led her organization to achieve and sustain notable trends in patient care outcomes, specifically in the integration of worker and patient safety and person and family engagement. It's my pleasure to welcome Sara Brokaw.
Thank you, Becky. Similar to Dr. Martin, who knew that when you start on these journeys that you will be invited to speak at something like this? So it's actually very exciting to be here and exciting to know that, that my team, and it really is my team that's done it, not me. Obviously, most of us know that it's really our teams that are key in making these things happen. So, and luckily I only have 2 slides, so who knew? I must have known ahead of time I wasn't going to be able to see them, I'm not sure. But so here we go. I followed a nursing leader or Vice President of Patient Care Services who had been in that role for about 30 years. And she retired, so I was coming in with some pretty big shoes to fill. And when I first started at the Bellevue Hospital, one of the things that I embarked upon, and again, at the time, I didn't realize it was going to have such an impact when we went on the patient safety and worker safety journey, but we really started to talk about values-based versus rules-based culture. And I worked a lot with my frontline leaders and with the frontline staff to really instill the values, and you can see them across the bottom of the slide. So we have core values and core processes at the Bellevue Hospital, and we really focus on utilizing these as the framework for decision making. I worked really hard to try and have individuals understand that we weren't going to have a policy, a rule, something in place for every single situation, but when anything is in question, you come back to this framework and you can't go wrong. And one of the things that we started with is keeping patients safe and keeping our workers safe. And it tied in very nicely as we started to work with OHA, with the Partnership for Patients. And again, that was the framework. So the question is, we have a decision to make. We're at a decision point. Where are we at with our core values and core processes? We don't have a policy for this specifically, for this unique circumstance. Are we keeping patients safe? Are we keeping our workers safe? So that was one of the things that we embarked upon first, was again, that values-based versus rules-based. And that was really important for my team as we began to develop and engage the frontline staff in all of these things. So tied in with that, empowerment. So when they had these core values and core processes, they suddenly felt like they could begin to make decisions from the front line and also from a leadership perspective without consequences. Were they going to make wrong decisions? Possibly, okay? But when they were making decisions, we were always going to keep patients safe and our workers safe. Other things we can repair, we can learn from, we can improve, we can grow. It's an opportunity. But again, it always went back to that safety aspect. And the empowerment of the frontline staff to be able to do that was huge in their engagement, because suddenly, not only did they feel like they had a voice, but they were making individual contributions that they could feel on a regular basis that led up to moving the organization forward. The other thing is tier huddling and consistency. So these kind of went hand in hand. The tier huddling, so all of my leaders, they will huddle first thing in the morning with their teams. Typically, if they have night shift and day shift, they'll huddle with them together. And the consistencies, they have standard work when they're huddling with their team. So they're asking the same questions and focusing on the same things every time. So their frontline staff know what to expect. And so those questions are, do we have any quality or safety issues regarding patient safety, worker safety, that we need to know about that happened in the last 24 hours? So were there incident reports that were filed? Were there things that I need to be aware of? Do we have a concern with a patient that's in-house? Were any of our workers hurt? So that's that conversation that happens during that huddle time. The other thing, we talk about other operational things. So we talk about throughput, and we talk about staffing. But again, it's an operational huddle, but the first question is always quality and safety. What issues do we have that we need to address? And then that information is brought to a leader huddle that we have. So all of the leaders are there together. And that's a huddle I run every day. There are clinical leaders as well as it's all leaders in the organization so that they're aware, because oftentimes we may need help from maintenance or we may need help from dietary to be able to solve some of the quality and safety issues that are escalated. And then the expectation is that my leaders, once we've had the conversations at those huddles, go back, close the loop with their frontline staff so they know I'm not just reporting things up and nothing's happening with it. That was one other thing that I found that was key with engaging the frontline staff. So they had the empowerment with the values-based. Now they have a venue, they have a way in which they're feeding information up. Where is that information going and what's being done with it? So is it just stalling, or are we closing the loop and actually making real-time adjustments so that we can fix these things? That was one thing that was really important as I spoke with my team, and they understood this as well, is that when they're feeding things up, it can't stall and it can't be a week. It really can't even be 2 or 3 days before you follow through, because the frontline staff, they really want that real-time feedback and real-time results so that they see the difference. We have other standard work that we've put into place, rounding on staff as well, and it talks about safety as well as patient safety, so not just staff safety. Feedback was the last thing that I wanted to touch on in this regard. So one of the things that we found when we started to talk with staff about violence against them, so we've run into that, and I'm not talking about patients who are confused and are lashing out, but situations in which staff are being sworn at, that they are being threatened. We've all seen it, unfortunately, and we've seen it increase in occurrence. And one of the things that amazed me is that the staff really felt, there were many staff that just felt that, well, this is just, we're nurses, we're caregivers, this is just what we do. So it was at that point with my team and with working with the rest of the executive team that we decided we needed to post signs throughout the entire building saying that this type of behavior would not be tolerated. And when we did that, staff started to really understand that not only did they not have to tolerate it, but there was a mechanism in which they could report when this happened so that they would then have executive or administrative support that we would come in and intervene. Because there's a certain point at which staff, it's too complicated for them to provide care as well as to try and stand up for themselves. And many of them weren't all that great at standing up for themselves, to be quite honest. There was a hesitancy to do so because they have that servant perspective, they have that caregiving perspective. But we found when leadership would intervene and come forward and provide that support, that empowerment then was fed even more. So it just became that snowball effect in that staff, they felt more empowered, they felt more supported, they were then even more engaged to be able to impact more change and are consistently focused in on keeping patients safe because they know that we're consistently focused in on keeping them safe. And those things were really what brought that together when we started on this journey. And again, I didn't know when we started with the values-based and the rules-based what impact it would have down the road when we started to become involved with OHA and the Partnership for Patients. The next step we took after we did the patient and worker safety initiatives was the Patient and Family Engagement Committee, or Council. And so it was based advisory as well as engagement and getting patients involved in the care. I know that that's kind of a hot topic out there right now. We decided to go about it a little differently, where we would not just have patients and families integrate into different committees that were already in place, but to actually put together a patient-family advisory committee, and that's all it is. So it's patients as well as leadership and frontline staff. And in talking with my team and how to best engage frontline staff in this, what we decided to do is have a frontline staff member who we wanted to have an opportunity for growth and development to actually chair this committee. And the patients love it, and the leadership. It's the leadership that we've seen grow from the frontline staff in wanting to engage with the patients and having them more engaged with their care, as well as the leaders deferring to the frontline staff for knowing how to interact with those patients to improve their engagement. It's been tremendous. So that was, I think some of us were a little nervous. Okay, how is this going to go? Because we've got leaders in the room, we've got patients and families in the room, and we've got a frontline staff member who might not be completely comfortable. It's been phenomenal. That individual has done a fantastic job, and I really, it's a decision that I would do over again and would consider with other committees in having those frontline staff chair those committees. So I was also asked to talk a little bit about obstacles. So we did run into some obstacles when we were on this endeavor. And you can see my quote there is really focused in on the fact that when we had obstacles, we came together as a team to figure out how to solve those. So that's always been real important to me, that I bring my team together and we talk about, okay, here's the issue. Let's talk about 20 ways to solve it, and then figure out what pieces, parts go together for the best solution. One of the biggest obstacles that we ran into was fear of frontline staff for reporting and again, for making decisions and not having consequences that would be negative as long as they were using that values-based framework. So that took a lot of work. I would say, again, fear was the biggest obstacle that we ran into. And I don't know that there was any one solution to this except for consistency and constancy of purpose around letting them know, you have to talk to us, otherwise we can't fix what the issues are. And ensuring that there were no knee-jerk reactions in saying that this was going to result in a negative consequence when reporting. So that was really important, regardless of what the situation was. We had times when policies were not followed, okay? But when you looked at the core values and the core processes, that situation it was important that that policy wasn't followed. I'll give you an example. People wanting to keep overnight guests, okay? And we have certain policies around how many, who, ages, that sort of thing. Well, a staff member, along with a night shift supervisor, made a decision based on our core values and core processes that people younger than the typical age were going to be able to spend the night, and there were going to be more individuals, because in their assessment, in doing core values and core processes, it was going to be safer for the patient. It was going to be, we were going to show greater respect for the patient and their families, and just a number of things that went into this. And so I think it's pretty powerful when you can sit down and say, okay, I understand that we didn't follow our policy, let's talk about why, and then to say, you made a great decision. Because in this moment, at that time, that's what was best for the patient, it was best for the staff, and now maybe we need to relook at our policy. Do we need to adjust this? Because, you know, I mean, there's times where those policies are wrong and they don't fit what our patients expect and what we're trying to do when we're doing that patient family-centered care. So that was really an important thing for us to embark upon, to be able to overcome that fear. And the consistency of having all of my leadership team react the same way. So that was kind of a little bit of reprogramming, if you will, because there was often, nope, it's a policy. But we've come a long way with that. We still have a lot of work to do, but we've come a long way with that, and it's been very impactful for the engagement of our frontline staff. That's all I have at this time. So thank you so much for your time. I appreciate it.
Thank you, Sarah. Just a reminder, if you have any questions, fill out your card and people will be around to pick them up. Our next panelist is James Middleton. James serves as Chief Nursing Officer at Knox Community Hospital in Mount Vernon, Ohio. He holds a Master of Science in Nursing degree as well as a Master of Business Administration degree from Kent State University. Jim provides oversight for quality outcomes and leads the patient care team of the 99-bed community hospital with 28 regional offices and practices. Notable strides in antimicrobial stewardship have been accomplished under Jim's leadership. I'm pleased to welcome Jim Middleton at this time.
Good afternoon, everyone. Thank you for having me. I'm going to start off a little bit. We're here to talk about quality and teamwork and team building. So, you know, at a small community rural hospital, we often get pushback and hear statements such as, why are we doing that? Or we don't have enough resources. So why is quality important? Do we do it for the billboards on the side of the road to attract more business? Do we make interventions and changes to have another gold star on a national database or on some sort of registry. No, we make changes because it's what's right for the patient. But how do we communicate that to the frontline staff? And how do we communicate and get their involvement? It can't be just the leaders that are making the changes. We have to have the involvement from the staff. When we talk about high-performance teams and building that high-performance teams, those high-performing teams, I often started thinking about, this is not like picking a team for dodgeball or kickball. Come on, I pick Janie and John and Roger to play on my team because we'll get better results. We want everybody on the team. And that means going across disciplines and getting outside of our comfort zones and working. And when we heard Dr. Barr and Dr. Scott talking earlier, they were talking about multidisciplinary approaches to team building and to better patient outcomes. And I think we have to remember that to come out of our comfort zones, move outside of the disciplinary, the disciplines of nursing, physicians, respiratory. Dr. Martin just mentioned, utilizing the nursing assistants. It takes a village to raise the child. It takes the entire hospital to make the change in an organization. At Knox Community Hospital, I'm blessed. I was blessed to work with a great leader, and he happens to be the president of the Ohio Hospital Association, Bruce White. And he often would tell me, as we were looking at quality metrics and quality changes that would affect quality, Jim, you can't boil the ocean, right? So who here has tried to think of 1,000 things they want to change and get them all done immediately? That's me. I'm like, it should be done. It should have been, but they should be doing that. They get it done. Hurry up, get it done. Well, you can't do that. And you have to break it off and break it down. So how do you go about doing that? And I'm like Dr. Martin. I'm going to have to kind of come around because I can't see the slides as well either. You start by doing a gap analysis. You have to look at your data. I'm the loudest Croatian in here, so I could probably scream and just talk to you all. But you have to be able to assess your data. Do a baseline data assessment. Where are you at? What are we talking about in terms of quality? Are we looking at falls? Are we looking at, hospital-acquired pressure ulcers? Are we looking at sepsis? Are we looking at antimicrobial stewardships? And use the data that's readily available to us. The PEPR reports. Utilize, the CMS data that comes out. The Ohio Hospital Association data. Earlier, somebody just asked a question, though. There's often a lag from the time that we report that data till the time we receive that data. And how are you doing? How are you doing compared to others? So, so you have to set internal benchmarks for yourselves and for what do you want to be? Where do you want to be? You can't raise a metric, those of us that are on Studer or have used Press Ganey for patient satisfaction scores, you want them up here and you're down here, but you can't jump instantaneously because what's going to happen the next quarter? They'll plummet, they'll fall because you can't sustain it. You haven't built and hardwired anything yet to sustain that process. So you really have to start and build your plan. Who here has walked onto a nursing unit and you're looking at somebody and talking to a staff member and you're saying to yourself, they have something to say, but they're not saying it. And Sara mentioned this. They have to have that freedom to speak up because oftentimes they have a solution to a problem or an intervention that may work. What works in one unit may not work on another. And you have to be willing to take those risks. Now, at the same time, we talk about standardizing work. We don't want work one way on Unit A and the same work different on Unit B. But oftentimes the units are not like units. And that's where leadership comes in and has to filter through that and be able to use their clinical judgment and their professional judgment to integrate what works properly. And I can't see again. I'm sorry, I feel like, let me see. create a team that is create a team that's free to make mistakes. Because what happens if you make an intervention? Let's use patient falls for an example. You know, everybody is using the bundle for falls, you know, but how do you know if you're doing better or worse? You know, you have to look at your interdepartmental data, and then you have to benchmark it to other hospitals, and what are they doing? And does the unit, it may mean changing your care delivery model. It may mean changing your staffing matrix of day shift to night shift. You know, breaking that data down. At Knox Community Hospital, we looked at the time of fall. We looked at all incident reports for all falls. And I was very surprised to find out, when do you think most falls occurred at a rural community hospital, at least ours? I was thinking night shift. It happened at 12 noon, right before lunch, and at 5 o'clock at night. And I was very shocked by that data because I was thinking, oh, well, most patients would fall during, you know, they get sundowners and they're trying to get up out of bed at night. So what did we do? We put more nursing assistants out on the floors during those hours. People were trying to get up to go to the restroom and to wash their hands before the meals came. So we really made sure and made it a concerted effort to get the aides out there to offer those services right before their meals came. And we noted that our falls plummeted exponentially. Now, what happens the minute you take your eye off of something? People revert right back to their previous behavior. So you have to hardwire that behavior. So the minute we took it off, our eye off of that one metric that we were looking at, we noticed another spike in falls. And so who hadn't we engaged enough in that process was the frontline staff. And so we really had to go back to them to say, this is why it's so important. And we all know the clinical significance of falls in today's market. And just nobody wants to call a family member up to say, your loved one's fallen, broken an arm, broken a hip, has a subdural hematoma. Nobody wants to make those dreadful calls, but they happen. Every one of us in this room is aware of that. So, you know, standardizing work. And so if, you know, at a small community rural hospital, you have to remember people float and float a lot, and nobody likes to float, right? Because I go to that unit and I don't know what they're doing. I don't know what their schedule is. I don't know what time their meals come because they come at a different time on that floor than they do on my own floor. So trying to standardize as much as possible really makes a great, great impact on your quality metrics. And you have to get everybody involved. The frontline, if you do not involve your frontline staff, and I go back to the Neiman Marcus model of building a team, you know, their pyramid is not the leadership at the pinnacle. Their CEO is not the pinnacle. They flipped it. The CEO is at the bottom, and the frontline staff is who runs the organization. And we as healthcare organizations have to remember that. And engaging your senior executive leadership team to help guide that is going to help build that team and build that confidence in them so that they feel comfortable in problem solving and solution solving themselves so that their metrics start to improve. You have to get the results, however, of those metrics out to them, and Sara said that, in a timely manner. You know, and I think the gentleman that was saying, you know, I can't wait 6-8 months for the results to be given back to me. The faster you can get those results up and posted, the better off you're going to be, and the more buy-in you'll get. And you have to look at all, is it people, is it process, or is it technology that's driving those metrics, or a combination thereof, and where's your gap? Measure and continue to measure. Okay, when I worked at Knox Community Hospital, our vice president of quality had a great, you know, we get all this data, right? We continue to gather data. Gather data, gather data, gather data. What are you doing with the data? Gathering data and sticking it up on a bulletin board is not making a change. And then staff feel like they're doing work just to do work, more work. So you find your informal leaders and your people that have a passion about a fall, have passion about pressure ulcers, who have passions about sepsis, who have, and getting buy-in. And from the physicians, who here has heard anything from their physicians? Dr. Martin talked about the two different definitions of sepsis, but we hear doctors saying, but we don't like the sepsis core measure. We've all heard that, right? And none of us in this room agree probably that, it's a pass or a fail when it's 140 some odd questions to just get the pass-fail. We all feel kind of slighted by that. However, it is what it is, and that's what we're dealing with. So we have to continue to build upon that and get buy-in and show them the evidence and use evidence-based practices to guide what we're doing. But we have to use those people who have a passion for that one metric that we're trying to change. Don't boil the ocean. You can't boil the ocean, Jim. And we use a continuous process improvement. We use Lean at Knox Community Hospital. And continuous process improvement is sort of integrated throughout Lean. And when I had the privilege of working at the Cleveland Clinic for many years, this was our mantra. It was continuous quality process improvement. And we were lucky enough to have wonderful quality directors there that were integrated into each institute that helped us get real-time data, that we could get it to the frontline staff, that we could make fast, quick nursing interventions or physician intervention changes so that we could have quicker results in front of the staff, that almost immediate gratification to make sure that things happen and people felt that they were being heard and that their efforts were making a difference in patients' lives. Most people want to know that they're still making a difference. And I hear it every day in just about every realm that I'm at that, it's generational differences. No, everybody wants to know they're making a difference. And we can show that through data, but the faster we get it in front of them, the better off we are. And that's how your team gets stronger and stronger. And as leaders, we have to allow them the latitude to make those changes and guide them. And, Rob was talking earlier at Licking, and I know many of the people from Licking, it's sometimes hard to put data out there, right? Because your data is not what you want it to be. And if your N's really low and you have a really bad outcome or a poor outcome, and you have to post it and share it, it's not the most comfortable thing because you have to answer to that. And you have to be able to explain it. But you can also explain them what we're doing. So this was the continuous process improvement model, and this is throughout, and this is what we use at the Cleveland Clinic. And standardizing work teams and, how do you measure if it's being communicated not only upward to the senior administrative team, yes, the chief nursing officer and the chief financial officer and the chief medical officer, we all want to know those things. CEO, the board of trustees, we report it out at quarterly meetings or monthly meetings. But we also have to communicate it to the frontline staff. And that's where your Gemba walks, using, round through your units. Do you have a bulletin board? Do you have a place where the quality metrics and your teamwork is displayed? Years ago at the Cleveland Clinic, in the ICUs, we posted days since last infection, days since last fall, days since last, VAP, CAUTI, CLABSI, and we posted it where the public could see it. Boy, let me tell you something. The nurses really, and the doctors and the residents really took note to that because families were then asking, what are you doing to prevent it? And it made a huge impact. We utilize doing done boards at Knox Community Hospital. And a doing done board is a bulletin board which just describes that, what we're currently doing, and it's anonymous. So staff who don't feel comfortable enough to speak up will utilize these bulletin boards, things that they want to see us start doing and then things that they say, things that are completed. But they want to see the results from those do, doing, and done boards. You know, we have to, I can't remember, see the last one, leadership huddles, leadership rounding, whiteboards, you know, all of those can continue to drive your outcomes. You know, if you look at your HCAP scores, at your patient satisfaction scores, those are all quality indicators. You know, we've talked a lot about, you know, early mobilization in the ICU. We talk about, you know, falls, any of that, but it's all driven, it's all quality metrics driven, and it's what makes an impact on our patients. I really would like to make a suggestion, though, is only measure what you're going to work on. Because again, if you're measuring too much, it's just data overload. And pick and choose wisely. And I go right back to what Bruce told me. You know, some things we have to measure because it's publicly reported. But don't over-measure. And really be smart and filter through what you can. And communicate that. Staff meetings, nursing newsletters, quality quarterly nursing town hall meetings. I have town hall meetings once a quarter, and it's required that everybody attend at least 3 of those 4 meetings per year for their performance evaluation. You know, and they want to come, and they start asking questions. What's happening with the CG caps? What's happening with the ED caps? What's happening with, you know, why is our fall rate so high? Why is the phlebitis score so high? Why are you, and, you know, so then you can start and talk about it. That's why we're asking you to do this. That's why we're asking you to make sure that you document on this line in Epic or on this line in Cerner or all scripts, whatever. So we can gather reports, so we can get that information back to you in a more responsive time. You know, and then you have to celebrate, you know, the wins, you know, and years and years ago, for those of there's a couple people here that got their masters with me, and we had the privilege of hearing Michael Campbell speak to us, and he was the president of MCI, or WorldCom, I should say, and he had like a $1 billion budget deficit that he had to fix, and he called it the power of pizza. You know, the power of pizza does great things. Take pizza to your staff and listen to them. They have something to say. But celebrate your wins. And be cognizant, not everybody wants to work on the same thing. We all have a lot on our plates, and putting more on there is one of the things that you have to be cognizant about. Form specialized groups, subspecial groups that can work on, you know, you're going to work on pressure ulcers, or you're going to work on infiltrates, and you're going to work on CODIs, and you're going to work on CLABSIs and ventilator-associated events. But form your teams wisely, because in a small rural community hospital, you have limited resources, and everybody can't be on every committee. So that, you know, forming your teams is not like picking your team for dodgeball. And that's all pick your teams wisely.
Okay, if anybody has question cards, just hold them up, and our circulators will pick them up for you and bring them up to the table. We'll start with, we do have a couple of questions, and I'm going to start with Sara. So a few questions kind of tied together, so I'm going to combine a couple of those that are very similar. For Sara, I'll ask both questions. The first question is, huddles can be controversial. If you discuss incidents in your huddles, do you worry that it's not protected under the Ohio quality and peer review laws? And the other question about huddles is, our hospital has had similar leader daily safety briefing every day at 8:30. In the past few months, we've noticed less engagement of our leaders for staging throughout the call or signing on, or staying throughout the call or signing on. how do you refresh or rejuvenate the brief of the call?
Okay, so I'm going to answer the second question first because that's less controversial. How to rejuvenate? You know, the first thing I would do if to see disengagement of leaders in a huddle is to ask why they're not finding it meaningful. So what is it that needs to happen in that huddle that makes it meaningful to them and that it makes it, you know, time well spent? You know, we share data in our huddle. So we talk about throughput times, and we talk about, you know, there's some accountability pieces in the huddle as well. So it's, you know, not just safety, although we start with that, there's meaningful opportunity to say, okay, lab turnaround times have slipped off this week, and now so has the ER turnaround times or throughput times. So where's the accountability? Lab, you've got to work with me so that we can get the ER where it needs to be. So that's the first thing I would do is say why, you know, I've noticed that people are not as engaged, they're not paying attention, they're signing off the call early. The expectation is that we're all engaged here as leaders. We own making these things happen for our frontline staff. So what is it that we're not finding valuable? What do we need to add? Or what do we need to not discuss that we don't feel is value added? So I would really just ask them and you know, go to the individuals who are a part of it. As far as the peer review, you know, that's a fine balance, and there's been some times where we have probably treaded on thin ice because it's important that another patient not be hurt in the same way, and it has to be taken care of in an immediate time frame, because if in 7 days to be able to bring together the right people, if there's any risk that in those 7 days somebody else could possibly be hurt or put at risk, for me personally, all bets are off, because we have to protect our patients. And I feel that that really stops with me. I mean, that's, if a frontline staff member doesn't have what they need to be able to take care of a patient safely, it doesn't matter when it happened or how it happens, it's me, it's on me. And so we tread close to that line. That being said, I really moderate that carefully. Huddles can be controversial. There's times when my leaders come into that room and they'll say, well, registration did this last night, and I'll go, whoa, time out. Did you talk directly to registration? This is not a huddle issue, okay? This is a people or a personality or a process issue between your two teams. Did you talk outside of huddle? If it's going to involve, and we've set some guidelines, so if it's going to involve 3 or 4 departments, then it becomes huddle. If it's 2 departments, you need to deal with it outside of huddle. If it escalates to huddle material, then that's fine to bring that. But that's something that I moderate and will redirect. Do parking lot, it needs to be addressed after huddle. And if we are getting into ground where there's discussion that might be peer review sensitive or, you know, violate certain things, then we say we need a smaller group. Not everybody in here needs to be involved in this conversation. However, we still need to fix it. So that's why it's so important that I'm at those huddles, to be able to you know, rein in those types of conversations. But we do, again, as I said, we tread close to the line because it's that important that we address it to keep our patients safe.
Okay, thank you. The next question's for Dr. Martin. It says, I loved your message as to all hands for quality. How can your message be carried out further and amongst the ranks of other staff outside of the nursing departments?
I think that's a cultural issue that you have with the hospital. It's to value every person. You know, we just went through kind of revising our commitments to patients and had people from nursing staff, housekeeping, everybody participating in that. And simply to say everybody matters in healthcare. You know, a great example, a number of years ago, we have a smaller hospital, St. Thomas, a visitor went down in the parking garage, and when the code team arrived there, the parking lot attendants started CPR. The security guard had an AED on the patient when the team arrived. Everybody matters in that kind of care. So if it's housekeeping and they say there's something wrong with the patient, you go investigate it. You know, everybody watches patients, everybody cares, everybody looks for what's going on in the institution. You know, we have a lot of people in the physical plant in the hospital, and I know you can appreciate this. It's easy to get lost, and everybody's walking people to different departments, taking the time to do that. So it's part culture is to value everybody, because at any one time they can save somebody's life, or they can, you know, make somebody's day go better. Just a, you know, pleasant word to a family member can mean a lot in patient satisfaction. So, you know, you start with valuing everybody that works there and what they contribute to care.
That's a great example. Thank you. This next question's for Jim. I really liked your grouped gaps, people, process, technology. Do you use it in all departments? Should we? Also, when you say don't overmeasure, what's a good amount of time for a snapshot and to get moving faster?
Well, people, process, and technology is jumping sort of, after you start to gather some of your data, you have to group it and sort of look at it and evaluate which sort of bucket it belongs in as you then start to look at forming solutions. I don't use it in all departments. We utilize it in nursing, which I wish some of the other departments would start and utilize it as well. Now, we do utilize it, the people, process, technology, when it goes cross, just when it's one department to another department. Because was it just two staff members disagreeing? Was it a technology issue? So we do utilize it there. And then I keep track of that and report that out at my one-on-one with my one-up. And so it does sort of make a difference in that aspect. And then the second part of that question was moving faster and getting results. What's a good number? You know, I would say if you don't have a team lined up, or if you don't have the bandwidth to work on a problem, you can gather some baseline data just to know how you're doing, but don't overwhelm your staff and tell them we're just getting some baseline data. We're not going to probably be able to address this until a date. And then just keep, the more you can over communicate, but if you keep them in the loop, they'll know that at least it's on the parking lot, or that you're looking at it. You might get some Hawthorne effect out of it, but you can't over, you know, for nursing, I think if we look at just the nursing quality indicators, HCAP scores, and then the HINs, the things that we're working on with the state, I mean, that is really a lot of metrics to be measuring and making interventions and trying to make changes and improvements upon. And again, it's a lot. You know, that's not even with that doesn't even get into the peer audits and any of the other type of things that you want to work on. We all raised our hands, or most of you raised your hands. You know, we want to change a lot of things. We just can't get to all those things all at once. And setting priorities. That's the.
Thank you. The next question's for Sara. Do you use the core values as criteria for executive level decision making, such as approving new FTEs or acquiring new equipment?
We absolutely do. Those core values and core processes are used with every coaching opportunity that we have and every decision that we make. So when we're looking at, do we need to add an FTE? You know, what equipment do we need? What processes are a priority as far as what we need to fix? Where is our performance improvement? Where are those efforts going to be taking place? And it all goes back to our core values and core processes. You know, one of those is revealing quality issues. So it's a great opportunity to be able to coach frontline staff and then also know that we're selecting IT products that can give us good information so that we can reveal those issues, and as well as being able to purchase equipment that can make all of those things happen. So we apply those, that's our lens. So those 8 things are our lens for all of our decision making within the organization.
Thanks. The next question is for Dr. Martin about sepsis. Given the variances you mentioned in your criteria for sepsis, the SIRS versus the QSOFA, how do you recommend keeping clinicians focused on early recognition and early intervention?
My feeling is you pick what's the simplest. I think QSOFA overall is the simplest process to do. And for people that aren't familiar, the QSOFA has only 3 components: change in mental status, a respiratory rate greater than 22, and a systolic blood pressure less than 100. Once you have identified 2 of those, I think you have to consider, is this patient septic? After that, you can consult critical care or move the process on. But the biggest issue, I think, for us and everybody else is just early recognition. And out of the 3 of those, I think if somebody has a bad infection and has mental status changes, you're in trouble, the reality of that. But I would pick the simplest to explain, the simplest to recognize. It may not be specific enough, but you just want it sensitive enough that you pick out the people that are sick.
I have one more, another for Sara. What actions did you take to enforce a zero tolerance? Oh, I did that one, didn't I? Zero tolerance? No? So I have a double one for you again. What actions did you take to enforce zero tolerance to violence towards staff? And how do you intervene with patients who swear at nurses or otherwise verbally abuse nurses?
Intervention, again, as I said, really has to come from leadership, and I have led the charge with that. I'll give you an example of how the empowerment that staff have. I've gotten a phone call, probably one of the worst patients that was throwing things in the ER, swearing at nurses, really just completely out of control. And so the supervisor went in, and every staff member in the hospital has my cell phone, and they know they can call me 24/7. So they called, it was about 11:30 at night, and they put this gentleman on the phone. And I indicated to him that it was unacceptable behavior and that I could be at the hospital in about 20 minutes, and I would be happy to sit with him for the duration of his ER stay if he could not remain respectful of the nursing staff and receive the care that they were trying to give him. He was also a walk-in patient, so I reminded him that he made the choice to come to our facility, that he was not brought here by ambulance, that it was his own choice to walk into our emergency room, and he quickly changed his tune. So I think it's amazing once you remind them that they've made the choice to come in, we're wanting to care for you, and to let them know that it's not acceptable. And he said, there's no need for you to come in and sit with me. I will completely be respectful. I'll stop. Now, they don't all stop, and some of them do require, physical intervention as far as my presence being there. But my leadership team knows that I will do that. I'll talk to patients on the phone at any time, that I will go up and let them know that it's not acceptable behavior. The other thing, too, is that you get a feel for patients, and I coach my team on this, is to just simply ask them, because a lot of times when they're acting out that way, it's because they're scared, and we haven't met a need that they have. And so it's not that they have to take ownership of the way that that patient's behaving, but we have to take ownership of what can we do differently that won't instigate that type of behavior. So to say, you speaking to me this way is not acceptable. We have a zero tolerance for violence or verbal abuse towards staff. That being said, what is it that I can do for you? What is it that you're wanting that's causing this type of behavior? And oftentimes sometimes that anger shifts to tears and fear and frustration about a number of things. So it's really about talking to the patient. We have, again, the signs to let them know that there's zero tolerance, and it's included in their handouts that they get, all of their packets of information, and then it's reinforced by leadership when the staff push back. But then at the same time, the onus is on us that people typically are good and I think don't want to behave that way, but when they do, more often than not, there's a reason that we can rectify that will help to set the path of the relationship in a different direction. Sometimes that's not the case, and then it requires additional intervention, but that's really how we've impacted that.
Thank you. Our next question's for Jim. How do you get C-suite executives more engaged with frontline staff to facilitate quality improvement initiatives?
Well, I think everybody feels this angst, and if you report results upward and give them the results and remind them that outcomes drive practice, and you keep those numbers in front of them, and I often meet with the other members of the C-suite in one-on-ones and shorter, smaller conversations where they can ask questions and feel more comfortable asking questions. I think sometimes people feel, and I'm not trying to speak for other members of the C-suites, but there's not a one-stop shop solution to everything, and that there's small incremental changes. And how do we get those changes and make those changes requires sometimes resources, requires additional technology, additional measurement, but I think if you have the larger conversation, utilizing the data, and then smaller one-on-one conversations where you can answer questions and remind them of the differences. The chief medical officer and the chief nursing officer in the C-suite are in a unique position where they can really influence clinical practices because they have that knowledge and that background, and they can help drive those and push those initiatives forward and doing what's best. And it's data-driven and utilizing that data in a large group and then smaller conversations.
And I have a question for Dr. Martin. What do you recommend for focus upon, or what do you recommend we focus upon with our EMS community to recognize sepsis earlier?
I still think for those individuals, the Q-SOFA is best for those. If you have a patient you suspect is infected, they have pneumonia, they have other signs that, fevers, aches and pains, that if they have any component of the Q-SOFA, then you consider that patient septic, start the fluid resuscitation with them. And that's been our goal with the EMS that we're instituting now, is based on that Q-SOFA score. Because it's easy to train people and to understand. It doesn't involve laboratory equipment. It is a quick clinical assessment.
Thank you. I have another one for James. What do you look for when you appoint or choose a super user? Desires, willingness to serve, something like that?
Yeah, I think that, when you look at, it doesn't have to always be the most senior nurse. It doesn't have to be the most seasoned nurse or physician. It has to be somebody that has a passion for what they're doing or for what we're looking at changing or measuring. It could also be somebody with a vast knowledge. And so I tend to migrate and shift towards the synergy model and matching somebody with a really strong skill set plus a novice person so that this stronger person may mentor this younger person in growing that and building that team so that they can help drive the outcomes. But that it's not just one quality, it's a multitude of qualities.
Okay. We only have a couple more questions. This is the last one for Jim. What do you do when a benchmark or target is prescribed to your team and you believe that it is too lofty or unrealistic?
Well, that's happened, and that continues to happen. I think setting short-term goals and setting long-term goals as being some of the, drivers of that. Working with the team, with your leadership team, to make incremental changes that will affect and drive those outcomes or improve those benchmarks or your goal towards those benchmarks. I think, sometimes it takes a little bit of deeper dive of why they're so important. Obviously, if we look at something such as falls or pressure ulcers or mortality rates, we all want zeros, but sometimes those are unrealistic. They are unrealistic in a hospital environment, but how can we better get there? And I think it takes work, and it takes involving everyone. And I really don't believe in being autocratic. I think that in those situations, it must be very democratic and being realistic and setting the goals with your team and then holding the team accountable. There is accountability issues here as well, guys. This just doesn't, somebody mentioned it earlier on in the panel about these are not free passes just because maybe we set a goal and didn't meet it. That doesn't mean it's a free pass that we're not going to work on it anymore. There is accountability issues here, and as leaders, you have to hold people accountable. And I think the hardest part for all of us in this room is, we all have a bunch of saucepans that we're trying to bring to a boil without burning, and we're trying to stir a bunch of pots at the same time and get good outcomes and good results. And the minute you move one to the back, that one falls off and you bring it up forward, but you've only got so much bandwidth to work on these things. And it's, setting priorities and working with those. But I really think incremental changes and short-term and long-term goals for benchmarks that are really lofty, prescriptive goals.
Thank you. So our last question is for any of our panelists, all of our panelists. Is there any specific team building model or framework that you use or recommend?
I think one big suggestion I would make for most people when they start out these teams with a process is to pick a single standard. We saw that with sepsis, mistakes that we made. We saw that with heart failure that we're working through, is you take the fire hose approach. You pick a single standard that you process engineer, you educate, you push everything toward to get that one standard effective in about 80% of your patients. I think if you push more than that, you run the risk of losing innovation, and sometimes your process just doesn't work for every patient. So you aim for that 80%. And it's like Lego blocks. It might not solve all your problems, but you get that one standard there and you got one Lego block. Then you pick up another standard. That's another Lego block. And you continue to improve care. I think when you try to change 5,000 different things, for heart failure, sepsis, or whatever you choose, you're going to have a lot of frustrated people and have no idea that you're making process. So again, you take that, you educate toward it, you get the parameters that you want to measure that are realistic for that process or that standard, and you move forward with that one. And once you get that accomplished, then you pick the next one in that flow. But don't bite off a huge amount. Just be realistic with what you do and push that forward. So you spend less time deciding on what you want to do and more time on implementing it and ensuring that it's hardwired and takes place.
Anybody else? Okay, thank you. So that concludes our presentation. Thank you to panelists.